Good afternoon and many thanks for joining us again. Well, as you know, we're live today from our London studio this afternoon. Very smart, Max.
Yes, it's a great view, isn't it, we've got from our London studio. We would normally be here at the QE2.
But not today. Change of scene. But Westminster, very apt backdrop for our next session.
Yes, it is indeed. Yes, that's right. We have Sharon Lamb and Stefan Rao from legal experts McDermott, Will and Emery, joined by Alberto De Rosa from Centene Corporation, looking at political risk post-COVID.
And you can ask questions live in the session using the question area of the app, so please do so.
Great.
Now, let's bring the panellists onto the screen. Welcome all.
Thank you. Welcome, Stefan, Sharon. Okay.
Hello. Hello. Yes, I'm Stefan Rau. I'm partner at McDermott, Will and Emery, and I'm delighted to have this session with my London-based partner Sharon Lamb and Alberto De Rosa from Ribera.
Thanks, Stefan, and likewise, I'm very pleased to join you today. I'm a healthcare partner in London, office of McDermott, Will and Emery, and we are very privileged indeed to welcome Alberto De Rosa, who is the Chief Executive of the Ribera Salud Group. Alberto has had an extensive career in health sector, with more than 25 years of leading hospitals and hospital systems. In 1998, he was appointed Managing Director of the Ribera del Zira Hospital in Valencia, and this was one of the first public hospitals to be managed under a public-private hospital system based on a capitated payment system, the payment per patient, and with integration between hospital and primary care. This Alzira model has been celebrated as one of the leading models of integrated care in the world, widely praised as a forerunner of new models of care. Ribera is owned by the Centene Corporation, the New York Stock Exchange listed provider of health services and Medicare and Medicaid, and named as one of Fortune 500's most admired companies, and its other shareholders, Banco Sabadell, Spain's fourth largest banking group. I'm sure I'll pass over now to Alberto to tell us a little bit more about Ribera, that it is headquartered in Valencia, has hospitals throughout Spain in 4 regions, interestingly operated by different in countries with different political parties. And in recent years, Ribera has expanded internationally into Bratislava, where it has 10 diagnostic units, and into Peru, amongst other places. Alberto, thank you so much for joining us today. We're really interested in your views. Can't think of anyone better placed to join us on this panel. In terms of the questions, I think to start, we wanted to ask you kind of an introduction and then give us your thoughts on the kind of political and regulatory risks that come with the operation of a model such as yours.
Well, thank you very much for the invitation. And as a short introduction, let me start with 2 thoughts I want to share with all of you today. First idea is COVID-19 has been the greatest tragedy that we have faced in our generation. But I don't want this to make us forget the major challenges that the European health systems are going to face. They are challenges that were already on the table, macro trends of the system itself, exacerbated by this pandemic. These challenges include an aging population, the chronicity of diseases, the appearance of new technology, etc. Challenges that are going to continue to put pressure on system costs and to which we had to add the consequences of COVID-19. Longer waiting lists, late diagnosis of diseases, etc. What is more, we cannot lose sight of mental health, which is going to be a significant challenge at this post-pandemic stage. With this environment that we have to face, public-private collaboration is going to prove essential in order for the public systems to be able to provide an effective response to these enormous challenges of the coming years. Without adding public and private resources, without adding technology, investment, knowledge, we are going to carry serious problems along with us. The second idea, in addition to this, it's very important to understand the foundation and pillars of public-private collaboration, but especially to understand the relationship between the governments and the private companies well. From my point of view, there is some confusion when we speak about public-private collaboration, with there being many types of public-private kind of collaboration. One is the outsourcing of certain services, for instance, dialysis. Another is the agreements in order to give support to the management of technology, radiology, for instance, or waiting lists. However, today I want to talk more about the long-term partnership between the government and the private companies in order to bring knowledge, flexibility, funding, and efficiency to the management of an essential public service, as is the case with health. The important thing is to define the key concepts for a relationship between the government and the company in the long term. It is the government that in a democratic society has the last word on matters concerning well-being and public health policies. It is the government that has to be clear about the objectives and should establish a transparent relationship with clear rules of the game and a system for incentivizing private companies, which allows for a long-term relationship. Aligning the objectives and vision of public administration responsible for public health with those of the private company whose objective is to make a profit and stand the test of time. In my opinion and my experience, the word alignment is essential for a long-term relationship between the government and the company.
Yeah, that's that's something that we talk about, the wider implications. Because you're absolutely right, those pressures are there to start with. And it's interesting, we've had very similar pressures in the United Kingdom, where the longer term pressures were there beforehand. In fact, some of the proposals in the United Kingdom are to move to an integrated model. Following some political pressure, it has now been decided that the lead provider, that cannot be a private sector player, it has to be a public health system. With that in mind, how have you found the different regions to operate and the kind of political factors that have affected the hospital operation? I mentioned in the beginning, you've got different political parties in the areas in which you operate. How has that affected the risk with your hospitals?
Well, it's true that our experience, we started with this model in 1999, 21 years ago. And it's true, in that period of time, the political stability and all this kind of controversies around this kind of models, the public-private partnerships, were there, but I think it was more a debate, a political debate, debate in terms of thoughts, in terms of, the vision of healthcare. But it's true, in the last years, maybe after the crisis, the financial crisis of 2008, there have been some different visions. Maybe the populism now is more important than 10 years ago, and the influence of these kind of political parties that they want to give easy solutions to difficult problems maybe are transforming a little the political environment. And it's more difficult than before, but we have our main challenge right now is to do pedagogy, not only between the political parties, the professionals, but also with the citizens. We have to explain that a model, if we want to preserve in the long term our welfare model, we need to have a consensus between the private sector and the public sector, and to add values, to add visions, to add technology, knowledge between the public sector and the private sector. Understanding they are different, we have different objectives, but we can work together, and it's important it's important to assume these different visions. And in our management with the regions, well, I think we are professionals. We are not a political company. We try to be very professionals, but it's true sometimes it's difficult depending on the political strategy in each region.
Alberto, when you speak about populism, you refer to populism from the very right and the very left, I assume. I mean, there's populism or not?
Yes, I think there are new political parties in Europe right now, and maybe in other areas, countries in the world, that they are trying to give easier solutions to a very difficult problems. Because of that, I wanted to start my speech talking about we had to face maybe the most important challenge in our generation, the COVID-19, but we have real problems on our table that we have to give solutions, and the solutions are not easier. We have to give solutions, and in my opinion, this kind of collaboration between the public administration with the private sector is a good way to give solutions to the healthcare system in the long term. It's true that now there are political parties that they try to the approach to all these challenges, they try to give very easy solutions to this kind of problems.
And do you see that in view of COVID-19, which, as you said, obviously affects us all heavily globally, do you see more trust among the public that the private-public cooperation is a good thing, or do you see more trust in the government itself, or rather in private players? Or is that difficult to say?
Well, I think the COVID-19 is a tragedy for our society, and it's true that we have seen some of the problems of our public healthcare system, at least in Spain or in other countries in Europe. It's true. I think this crisis, the outbreak, put our public healthcare system to the limit. And in my opinion, after the pandemic, there will be maybe more dialogue, more consensus that the private sector is needed to give solutions in the long term. In Spain, in the UK, for instance, I know that there are the public hospitals are receiving support from the private sector. In Spain, it's exactly the same. The private sector has given support to the public administration managing this outbreak. So I think, I hope that after the pandemic, some of this political debate around all these kind of collaborations, I think it will be a new era of trust between the two sectors, and I am optimistic because it's true that the public sector after this pandemic is in the limit, talking about waiting lists, talking about technology, talking about obsolescence of the investment, talking about the problem of mental health. So I think the public sector needs to the private sector.
Sharon, your country, as mine, is not unaffected by populism either. And obviously, COVID is also a big issue. What do you see now in view of COVID, and obviously also in particular of particularly a situation in London just in view of Brexit? Is there more confidence in public-private partnership? Do you see the NHS reaching out more for private cooperation programs or less? And what does the public think?
Yeah, I mean, that's really interesting. And Alberto referred to that when in his last answer, because through the pandemic, so at the very beginning, there was a partnership formed between the kind of private hospitals across England and the NHS, where effectively the NHS purchased the capacity of all private hospitals and then paid a kind of a capacity sum to keep those hospitals available for NHS patients. And those hospitals were repurposed for cancer, for some emergency type procedures, and for elective care. And I think without that capacity and that relationship, there would have been different capacity issues across the system. Now, of course, like most other countries, and interested to hear your views on this, Stefan, for Germany, the position, at least in the UK at the moment, is that there are approximately, best estimate of about 10 million people likely to be waiting for elective care. There is a doubling of demand for mental health services in a circumstance where mental health services were probably not as well provided as they could have been. And there's a clear question about how those people who have waited for care and or who've had their care delayed as a consequence of COVID, either because they didn't want to come into hospital or because elective care was shut, how the country is going to respond to clear those waiting lists. There's likely to be, I hope, a stronger and better relationship between the private hospitals and the NHS. It's well known that there's been some kind of anti-private sector feeling, at least in the UK, but hopefully the new relationship will forge a kind of different path of relationship. But interestingly, prior to the pandemic, there were proposals to change, and if we leave without any kind of regulatory system in comparison, a move away from the public contract rules, so procurement rules, post-Brexit, so that NHS services would be removed from the procurement rules. Now, that has caused some kind of concern and question to private providers because the replacement rules are not yet clear. And there is a question about whether that might mean that there is an NHS preferred provider model operating. And although that proposal was suggested pre the pandemic, after this relationship and with such a heavy demand for services, it will be interesting to see if that is affected at all by just the relationship that's developed through COVID. And Stefan, what has the position been in Germany?
Well, obviously, COVID has had a big impact. I am not aware, though, of longer waiting lines. For a long time, we would rather have said that it's rather the opposite. Elective care was avoided by the patients themselves. They were just afraid going to doctors' offices. It was certainly the case in spring up to summer. But still today, I think that there is still less demand in some practices and hospitals than there was before. So I'm not aware of longer waiting lines. However, our system is obviously quite different from the UK system or the Spanish system. As you know, the entire outpatient sector is exclusively private providers. It's obviously paid by the government, the public payers pay, at least for the 90% of the population that are covered by public insurance. But the entire outpatient sector, and a lot is obviously done on an outpatient basis, is private providers who can obviously be more flexible in offering time schedules and a service to their patients. This flexibility has also increased by the advent of private equity players entering the market against the resistance of some doctors lobbying association, particularly in the dental area, who were obviously afraid of competition from more efficient or more competitive providers who offered also services over the weekend or late in the evening. So outpatient sector, no. The inpatient sector, well, as most people attending will probably know, it's shared, split. A third of the market is done by public providers, public hospitals, community hospitals, state university hospitals. Third by non-for-profit, private, usually owned by some church groups, and 1/3 by private for-profit. But also there, I do not see that waiting lines have endured. But maybe someone is here in the audience and would disagree. I would welcome any comment or criticism or maybe support. What I always found is interesting is, although the UK health system is more, from my perspective, well, at least structurally, more dominated by the state, by the government, with NHS being a public provider and a public payer. There's, well, as you said, obviously a lot of private cooperation. But my impression is that the advent of private equity in the market is more welcome by the public than this is the case on the continent. Would you agree, Sharon?
Yeah, it's an interesting question. I think that the debate in the UK has largely been focused on whether providers are private, i.e. not governmental, as opposed to whether or not they are owned by private equity. That focus, which has been a key discussion, as I understand it, in Germany about private equity involvement in healthcare, hasn't featured in the same way. It's rather been expressed as a private provider, NHS or government provider. And also worth remembering that the UK system is, although it looks to be mainly governmental, NHS, all primary care in the UK is provided by private general practitioners. Almost negligible primary care provided by NHS bodies. And that is kind of commonly overlooked. So we have a kind of system where primary care is privately run, hospital care is 90% NHS run, with elective care as to about 12% being provided by private entities. Dental services are also privately provided, and a vast proportion of mental health services and care services are privately provided. On this, I'm interested in Alberto's view, because clearly one of the impact, particularly in, well, I think all countries, has been the vast amounts that governments have had to pay to kind of support social services and employees through the pandemic, and whether there will be a greater need for private capital for investment in technology and for investment in infrastructure. And that, I think, will be interesting to see in the UK, where there was a big hospital building program planned, but after that, it's fair to say we're going to have spent quite a lot of money supporting all other manner of systems in the UK. Alberto, what's your experience and thought in Spain?
Well, it's true that before the pandemic, but after this situation, we have some challenges that we had before, and now we have some new challenges. Technology, all the telehealth, big data, intelligence, artificial intelligence. I think there are a lot of new things on the table that, of course, this kind of collaboration between the private sector and the public administration will be higher and will be more important than ever. So this is my first reflection, that I can't imagine a public healthcare sector in the 21st century doing the same things that 50 years ago. So now all these kind of situations about the introduction of technology, the introduction of technological solutions in our healthcare system will be accelerated by this situation. So the needed of investment, the needed of knowledge, the needed of different ways to connect citizens, doctors, nurses, to connect primary care, to integrate the healthcare, to have a shared vision between primary care, hospital, home care, that it will be very important, social services. We have to be aware that, in my opinion, we will have to be in a different situation, and we have to give new answers for new problems, and we have to to be more open, and this kind of models of care will be absolutely more important in the near future than it used to be. So yes, I think all these kind of collaborations in Europe and of course in Spain will be on the table in the near future.
Alberto, from our practice, we have the impression that the Spanish market is particularly interesting and important, actually, also for private equity investors in the health sector, because there are less market anti-restrictions in Spain than there are, for instance, in France or in Germany, or also other Western European countries. And in some countries, you can really use a Spanish vehicle in the fertility sector, for instance. This has repeatedly been done. Can use a Spanish entity to establish subsidiaries in other European countries, and thereby benefiting from the European freedom of services. So if you are permitted to render services in Spain, you must also be permitted to render those services in other European countries. This is unfortunately not the view of the regulatory bodies in my own country, but many other countries take this view that the European freedom of services should also apply there. And therefore, the Spanish market has always been very interesting for us, and obviously for our clients. We say, well, we have a Spanish vehicle, and now we want to augment our services in Europe. Unfortunately, in Germany, not possible. Is that publicly discussed in your country, or the advent of private equity in healthcare? I mean, you are obviously also having a majority shareholder coming from the US. Is that an issue? Is that widely discussed, or not really in the public?
Okay. I think in general, well, of course, there are people for everything, but in general, I think we are an open country. In fact, the leader of the private healthcare sector in Spain is a German company that is they work very well. They have a hybrid model. They are working in the PPP model, public-private partnership model, and they have also some hospitals, more than 40 private hospitals, that they are collaborating with the insurers and with the public sector, but in other way. So we are totally open to this kind of investments. Well, I think it's good, because I think we have to think more in terms of European environment and European market, that thinking only in our own country.
I think Sharon mentioned it shortly. You are also active in East European countries. Do you want to tell us a bit about your experience there?
Well, my personal experience is, I think it's a fantastic area of Europe. I think they have a fantastic level of doctors, of professionals. I really think they are a very interesting market. It's true that, for instance, in terms of facilities or in terms of, they have some problems because they have all facilities maybe from 30, 40 years ago, and is, in my opinion, necessary to invest in new facilities because the society is a very dynamic society, and they have some problems of obsolescence in technology, and to invest in technology also it will be good. But for us, it's a very interesting market, and we are really interested to grow in this area of Europe.
Okay. And a question to you, Alberta, and also to Sharon. You, Alberta, mentioned repeatedly populism, and globally, obviously, and a consequence thereof is, that is maybe also not everyone's view, but it would be my view, there is an increased foreign investment control, also among Western countries where you would think they have the same belief in democracy, in tolerance, in a market economy, social economy. Nevertheless, increasingly, obviously, this started in the US. Let's see whether this is going to change. But the European countries are also trying to strengthen the investment control. The European Commission made related recommendations. And some countries, like France and Germany, for instance, have kind of stricted their foreign investment control on health companies, health service providers, but also pharma companies, not with much practical relevance so far, at least in my country. What is the view in Spain? Has the government taken any actions? And obviously, Sharon, we are also very curious to hear what we're going to expect in the UK in this respect after New Year's Eve.
Well,
Alberto, do you want to start?
Maybe I am an heterodox in this point of view, because I really think more private participation in healthcare, more public control. I would like to, if you allow me, in order to mitigate risk and to promote a long-term collaborative public-private model, I made some years ago a list, a decalogue, from my point of view and from my experience, that it will be necessary to implement all these kind of projects. First, a medium and long-term stable and legal regulatory framework. We cannot start from scratch with every new parliamentary majority. Second, solid projects based on planning, the establishment of priorities, and implementation calendars. Third, value for money. In other words, a clear optimization of public resources. Fourth, the definition of public objectives to be achieved and of private sector incentives so that they contribute to achieving them. Alignment of interest is essential, in my opinion. Fifth, more private participation, more public control. There should be a culture of governance in the public sector that goes beyond administrative bureaucracy. And because of that, we need a strong and active governments to manage this kind of new vision of the public sector. Sixth, appropriate choice of private partners. Companies with a long-term vision, transparent culture of public service management, in my opinion, are needed. Seventh, follows up and evaluation of experience. Transparency and accountability publicly is essential to incorporate the citizens into these models, into these projects. Clear contractual rules that can be reviewed in a consensual way, given that there are contracts, long-term contracts. Ninth, to avoid cultural resistance, both in government and the company, the lessons learned in these partnerships will have to be applied to the rest of the system. The creation of a culture of governance is crucial, in my opinion. And 10th and the last, we have to count on professionals. They are the main asset of our system, and they generate trust in the citizens. We had to go to the extra mile in terms of pedagogy. So I think after 20 years of experience, these are my 10 points that must be important if we think these kind of models are going to provide to the healthcare sector value for the citizens, for the professionals, and for the country.
Okay, so in terms of foreign investment control, you would think that the acquisition of Ribera by an American investor would still be possible also today?
Well, in terms of public control, I think it's important to have a high level of control of everything. It is a co-governance between, in my opinion and my experience, between the public sector, the government with the private company. We have to be very transparent, and I think the government must be active, must control the management of the project, and the private sector to be flexible, to give technology, knowledge, and to combine these strengths of each part.
Of course, yeah. And Sharon, what can we expect from your country? Very general question. You know how I mean it. Sharon? Hi, Sharon? Yes, okay. We hope that this is not a sign for next year that when Sharon is asked on what. Yeah, I was just saying we hope to be able to discuss these questions also with Sharon next year still. What is going to happen after New Year's Eve? Is there going to be an increased foreign investment control for health companies and others acquired by European or other investors? Anyway, I think we have. Sharon.
Sorry, I don't know what happened there. I was first going to say that Alberto's list of priorities for investing sounded like honestly an excellent checklist for anyone investing in healthcare in any country, and if only those priorities could be maintained by all governments. There is a saying sometimes attributed to Nye Bevan, who is the founder of the NHS, that if a bedpan is dropped in a hospital in South Wales, the sound will reverberate in Whitehall. And that's how strongly the government and our political parties view the NHS. And I will say that after the pandemic, where we had a Thursday clap for the NHS, that was likely to be even more so than before. And so actually it's quite interesting that has always been a dynamic in the UK. So the NHS is always on the agenda for all political parties. And there is always a kind of risk about what is called in the UK a top-down reorganisation of health services. Interestingly, whilst we, of course, are waiting to hear the news of whether there is a deal between the UK and Europe, we thought the deadline was yesterday, and we still await news. Hopefully, only good news in the next couple of weeks. That the UK government has always had a very relaxed view on foreign investment. So typically, the United Kingdom has been a very open country for investment. But in July this year, the merger control rules were changed, so there was a lower limit imposed. And separately, in November this year, a new foreign investment control regime has been issued. It's subject to consultation, and that actually proposes that critical suppliers to government, they don't actually specifically name health systems and hospital providers, but there is a line in there that says if you process the data records of more than, I think it's 5,000 data subjects, which would cover most hospital systems, that may be a critical supply to government, and that also might cover pharmaceuticals and other industries. So it does seem that alongside the rest of Europe, we're moving into a regime where there will be greater scrutiny of the acquisition of UK assets, whereas previously that was kind of defence and national security. The definitions are quite widely drawn in the UK. Have you got something similar, particularly for pharmaceuticals, Stefan, in Germany?
Yes, even though in Germany this is not linked to the merger control, it is not something that the competition authorities would look after. It is an individual scheme managed by the Department of Economic Affairs, where there is basically a control of foreign investments, and some amendments have been implemented where under health companies have to be scrutinized as well. That is the case with very large health systems. We see that when private equity investors buy hospitals, that the foreign investment control also under the new regime is not applicable, as the hospitals are usually not as big enough. But if someone wanted to buy one of the largest hospitals of the country, then this would apply. Would we face the risk that such potential acquisition was boycotted by the Department of Economic Affairs? I would rather doubt it under the current political conditions. That we have general elections in fall, and thereafter we could obviously have other people making decisions, and the laws allow us to veto these kind of transactions. We have the same thing, obviously, with smaller pharma transactions, as you can imagine, particularly in the lab testing and medical devices, in vitro, but also pharma sector. We have a lot of transactions in the smaller mid-cap sector currently, and this is an issue which we have to look at, which we have to face, but we have not seen any relevant opposition so far. But that's the implementation. The law would allow to do it.
Interesting, actually, because that's what the
Lightest
point I was. Interesting, and because the new proposed UK regime will also be standalone. So previously it was just in competition control. The new proposal is it will be a standalone regime, so similar to Germany and similar to previous, so that is actually a significant change for England or United Kingdom, or will be for next year. Just in kind of closing kind of comments, I see we've got a question there, Stefan, about jurisdictions due to critical infrastructure.
Have you seen the jurisdictions? The question is whether we have seen an attempt by the governments to control healthcare infrastructure as a critical infrastructure. Yes, hospitals with many patients are considered critical infrastructure. That was basically what I was referring to. So smaller hospitals, no, they do not tick the box. Larger health structures do tick the box as a critical infrastructure.
Yeah, that's interesting. Hospitals are not specifically named in the UK one, but might fall within the critical suppliers. Okay. Just in our closing moments, Alberto, thank you for your very impressive list of what would be the right criteria and what would be the best kind of environment to invest. Are there any steps that you think that providers should take to mitigate against changes in political risk? I mean, is it as simple as being clear about the high quality of services that are provided and the benefits for patients?
Well, it's true that quality of the management is really important. I think we have to attract the professionals and the citizens to this kind of projects that maybe is difficult to explain to them, but we need this attraction, this approval to avoid the political debate. I think it's very important if this idea of pedagogy to be close to our professionals and to the citizens, because they are the real and the final actors of everything. So I think my recommendation is to not only about quality or innovation, to be close to the professionals and to the citizens.
So being able to engage and explain clearly the benefits to patients and to citizens, the benefits of private investment and private care bring. I completely agree, and sometimes a narrative that can get forgotten in the wider discussions. Alberto, thank you so much for your time. We really appreciate it. It's been a privilege to speak with you today. Stefan and I are very grateful for you joining us in this session. Thank you.
Thank you very much. Thank you. Goodbye.
Well, welcome back. You'll have a chance now in a moment to catch up on the last session, have a look at that session, but you need to rate the previous session before you're allowed to do any of that. So do, when you have a moment, go on to the green link below and just click on the app and be released to your coffee. We can't emphasise to you enough just how important your feedback is to us. So many thanks for doing that. So we'll have a 10-minute break now, and then afterwards we'll come back for what promises to be a really interesting interview between Max and Sophie Boisson of Corian. She's the CEO there. Look forward to seeing you then, 1 o'clock.